Coming to the first topic, that is the management of primary tumors. When we are suspecting a tumor, definitely the management of any medical disease starts with the basic history. There will be definitely cues in the history which will point out that most likely this patient does not have any trauma related associated problem or does not have a degenerative associated problems. Probably this is leading to some kind of a tumor. But then there are definitely other conditions which sometimes mimic tumors in case, for example, uh, simple as soft tissue hematoma. But in case with the difference between soft tissue hematoma and tumor is that usually this swelling in the case of hematoma is always post-traumatic. But soft tissue tumors and even the bone tumors sometimes can present with a swelling without any history of trauma. The other includes such as myositis ossificans. Now, the problem with the myositis ossificans is usually the associated history of trauma as well, but post periarticular calcifications sometimes mimic chondroid variety of tumors such as chondroblastoma or chondrosarcoma. But depending upon the usually in case of chondrosarcoma, definitely there will be age more than 40s and 50s. Patient will be in late 50s or late 40s. Then definitely there will be no history of trauma associated pathology, and patient will also have other symptoms of tumor such as cachexia, weight loss, and anorexia and all that. But usually in case of myositis ossificans, it's just purely fluffy exudates which can be usually seen around the soft tissues, although they are less painful and they are usually better defined. But sometimes when we are dealing with making a differentials, then we may have to put the chondroid variety of tumors as a part of a differential of myositis ossificans, because they are also calcified, while in myositis ossificans this usually calcifications also appear as white speculated density as well. Others include stress fracture. In case if it's mostly stress fractures usually occur in soldiers or those patients which have to do a lot of hard manual labor. Usually the history would be pointing out if in case a soldier who comes with a history of pain, and especially due to long prolonged standing, then there may be associated stress fracture. But if a child comes in and there is history of swelling and there is also history of pain and you cannot appreciate any fracture and there is no associated trauma as well, then you must be thinking on different lines than stress fractures. And usually cortical destruction is seen sometimes if that structure is in a healing phase. Usually healing callus is sometimes visible as well, and there may be a periosteal newborn. But now this is different, that if periosteal newborn and onion skin like lesion is seen, it's not specifically point out to Ewing sarcoma as it is common with Ewing, but sometimes you have to keep in mind that it could be stress fracture, it could be Ewing sarcoma. So we have to keep both in differentials in mind. Coming to tendon avulsion injuries, sometimes they do mimic because once the tendon is avulsed from its base, usually the mass clumps in and usually presents with the mass. But that just not sometimes can mimic some kind of a soft tissue tumors, but usually it's very rare. It's common, tendon avulsions are common at the site where the tendons are actually inserted, usually hip and knee, while in case of tumors, they will not be probably present in soft tissue sarcoma, that will be in the muscle belly, not the tendons where they have avulsed. Coming to infection, if a child comes to you with history of bone pains, malaise, swelling around the knee, and then there is associated raised ESR, TLC, as I'm telling you, the first thing which comes to mind is infection. But usually this is exactly what happens in case of Ewing sarcoma, that it mimics infection in such a way that sometimes it's very difficult to differentiate infection from Ewing sarcoma. So it may be osteomyelitis, it may be Ewing sarcoma or Ewing sarcoma. In case it's sometimes very difficult to differentiate between these two. Other tumor conditions which actually mimic bone tumors are, for example, if it's gout, usually gout presents with swelling of the first metatarsophalangeal pit, Uh, this could be due to some kind of the exostosis, which may present with swelling, but there may not be associated with so much pain, swelling, and redness. On the other end, osteopetrosis is also a disorder of bone in which there is increased bone density because the osteoclasts are actually defective. As a result, the osteoblasts are laying down a lot of bone. What results is this usually presents with thick cortices with sclerotic bone. Sclerosis can be a sign of a pathology as well, especially sometimes it's very difficult to differentiate between those tumors which are producing an osteoid matrix to from those osteopetrosis, because there's almost similar kind of sclerosis involved. Then other disease which is usually osteopyklosis, it's also autosomal dominant sclerosing bone dysplasia, and which presents with multiple bone islands. And sometimes because there are multiple bone islands, they usually sometimes it appears that there's some kind of a new bone, and more osteoid variety of a matrix is being laid down, maybe due to some kind of a tumor. Then the other condition which mimics tumor is called as melanocytosis. It's basically a disorder of mesenchymal dysplasia. The classical presentation is the widening of sclerosis of cortices, and the most pathognomonic on X-ray is candle wax appearance. If you see the X-ray of melanocytosis, the classical presentation would be of candle wax. Now, this diagram is related to gout. If you see this thick, large cortices with almost obliterated medullary cavity is classical presentation of osteopetrosis, and usually these kind of the bones have become brittle. So this is kind of a subtroch fracture, the osteopetrosis. Most commonly in osteopetrosis, you really have these kind of subtroch fractures. And if you see this hand X-ray and see the first, second, third metacarpal, usually it appears inside the cavity. There is a dripping wax-like structure. This is a classical presentation of melanocytosis. So coming to the principles of primary bone tumors. Whenever we have a doctor is examining a patient as we are confronted with a disease, the first and foremost is always the start of history. Similar is case with the tumors as well. They start with the detailed history and examination. You have to start with the history, what was exactly, whether it was just pain, was there any associated swelling, or was there associated night pains or nocturnal pain as well? Was it relieved by some kind of taking any medication or not? Is it progressing? Is it associated with some other kind of deformity as well? And then comes the examination. Then from history you go to the examination, and if the patient has presented with some kind of a swelling, then not only the local examination of that swelling, but also the overall generalized examination to rule out other systemic morbidities associated with that swelling. So the principle of surgical treatment, if we know once we have made the diagnosis that yes, this patient has tumor and some kind of a tumor, then comes the principle of resection, that whether we take that tumor out. If it's benign, can we leave it? Sometimes in case of UBC, if it has presented with a fracture, nothing needs to be done. We have to just give the splint and allow it to heal, and usually it heals. But if that child has presented with osteosarcoma or Ewing sarcoma, then these are very highly malignant tumors, and you cannot leave them. Then you have to do some kind of a resection. So it's on this basis actually how the margins are being taken during the resection. Actually, it's been divided into three different categories. This one is intralesional, as the name suggests. That is that the tumor, through the tumor is actually the cuts have been taken, and definitely the tumor the postoperative histopathology on postoperative histopathology, the positive margins would always be present. And then it is a marginal excision, as the name suggests, just through the margins. That usually tumors have a pseudocapsule around them, and once that all the tumor, including the pseudocapsule, has been taken out, this is a marginal resection. But if we are taking a healthy tissue out, That's at least a good chunk of healthy tissue. Usually in case of femur, it's 5 to 8 centimeter. If we're taking a good chunk of healthy tissue out along with the tumor, then it's wide local resection. And if we're removing the whole compartment, for example, if a patient presents, let's say 45-year-old patient with pelvic chondrosarcoma, now you cannot probably do wide local resection because it has a very high malignant potential. So you may need a whole compartment to be excised, which will eventually end up in some kind of an amputation. So if then removing the whole of the compartment, which may eventually lead up to some kind of amputation, this is called as a radical resection. So depending upon the kind of a tumor, usually for malignant tumors, wide local or radical resection has to be done. But for benign aggressive or benign tumors, intralesional or marginal can be done. As I just told you, primary operable tumors, usually it's called as excision or limb salvage and amputation. Now usually nowadays amputation is rarely performed, but yes, maybe in 20% of cases we have to perform amputation. Why? Because sometimes the tumor has already advanced enough that probably the amputation is the best chance. But nowadays people are moving towards limb salvage because usually the tumors, especially malignant tumors appearing in children, they carry a lot of morbidity post amputation. So therefore really the first effort is made towards the limb salvage. Then this next mechanism is that resection with the clear margins. As I just told you, intralesional probably will contain, no, will not have a positive margins. So the margins of the tumor will not be, the margin of the tissue will not be free of the tumor. So we need to resect the malignant tumor, especially wide enough, so that the some degree of normal tissue that get taken out, so that the margins of the soft tissue which has been taken out are free of tumors. Then obviously preoperative local staging and imaging is always necessary, because once we make take the history, make the diagnosis after examination of the patient, then comes the non-invasive techniques, that is X-rays, MRI and CT and bone scans. Once all that is being done, then we plan for the biopsy. Once biopsy is done, then we know what's the final diagnosis, and after the final diagnosis we plan for the resection of the tumor, which could be intralesional, marginal, wide local or radical. Now, Anagans defined a classification which actually for the soft tissue as well as the malignant tumors, which was actually to classify the disease so that we know how much the margins we can excise. Now, coming to the type of excision, as I've just told you, if you see this diagram over here, this is the tumor which is present. Intralesional would mean taking some part of the tumor out, but not all of the tumor. Some tumor would remain in the body, most of the tumor would be removed. This is kind of intralesional. If it is benign aggressive disease, usually there is associated reactive zone or pseudocapsule has been formed around the tumor. If this reactive zone, most of the whole of the tumor is being removed and some part of the reactive zone is being removed, this is called as marginal. But when we are taking the normal tissue, a chunk of normal tissue, so that the margins, once been reviewed by the histopathologist, are free of the tumor, that is when we are talking about the wide local resection or wide excision. As I just told you, intralesional, marginal, and wide local resection. The main important point over here is that the malignant the tumor is, you have to take out the more normal tissue out. That is, either you have to go for wide local resection or radical resection, because you cannot leave even a part of a pseudocapsule or tumor in a malignant tumor inside the body following resection. This is the kind of a tricky decision whether to go for limb salvage or go for amputation, and to be honest, it has to be decided on the patient to patient basis. Nowadays, yes, there is a trend towards limb salvage, but sometimes limb salvage is actually more detrimental to the child. For example, if a child comes to you with aggressive osteosarcoma, and probably it's actually involving the, let's say, distal metaphyseal area, and it's involving the knee, and you cannot save the knee. One option is actually give it above knee amputation. go for rotationoplasty and give that child a good prosthetic replacement later on. Now that is rather much better than giving it a kind of a unstable knee later on with multiple mega prostheses. So sometimes you have to tighter whether you have to go for limb salvage or you have to go for amputation. And sometimes amputation, you don't need to perform a whole amputation. That is, for example, if we are performing above knee amputation of a child, we know that something below the tibia is usually preserved. And for example, if it's a tumor of the distal femur that is around the knee, probably 8 centimeter below that level probably will contain no tumor cells. So we can use that lower part of the leg as a form of rotationoplasty, and later on we can give that a prosthesis. So sometimes even the tumor has spread so much that the best option is that you have to preserve life first, then the limb. So that tumor has advanced to such an extent that actually started becoming a life-threatening event. So we given an amputation to preserve life over limb. Then this is actually, I was just talking in, for example, if this is where the tumor is, and you have to get a 5 to 8 centimeter of clear margins. You take this part out, this hole is preserved, and this whole part is actually preserved. We use it to rotate it out, use the ankle joint as a knee joint, and give it for the leg, give a good prosthesis. This is called as rotationoplasty. Usually, most important factors which need to be considered are actually governed by postoperative limb function and outcome. There's no point saving a limb which is dead or flail, or if there is no actually survival benefit. If you know the child is not going to survive for more than, let's say, 6 months to 1 year, then there is no real point of giving them a good limb salvage surgery. Other amputation would be better. Similarly, limb salvage usually is done for 85% of appendicular tumors. The important point, which is basically once we're doing the limb salvage, then what are the options for limb salvage? These include endoprosthetic replacements that are giving mega prosthesis. You resect out the tumor with the good clear margins and give a prosthesis instead of that. Other is allograft prosthesis combination, because nowadays bone banks are readily available in the world, and they usually store the different bones of the dead, and then that can be used as an allograft. The other option is actually allograft using donated bone, extracorporeal sterilization, then reimplantation of patient's own bone. That is actually can also be utilized, because bone graft is actually main important over here. And lastly is the autograft and orthodesis. Although it doesn't really mention the rotationoplasty, but usually it actually preserves the function of the limb without really use of a lot of allograft and use of prosthesis. But nowadays, with new techniques and newer endoprosthetic replacements, especially in case of children, those prostheses which can actually enlarge and lengthen over time, usually the incidence of rotationoplasty and orthodesis have actually decreased. But if you cannot do anything, you have to give it a stable joint. So the last resort which always remains is orthodesis. Coming to the limb salvage and amputation, furthermore, usually it's challenging in skeletally immature patients. Why it is challenging? Because if we amputate it, we know this the child is going to grow, the stump is going to eventually grow out of the bed. Yes, the other option is that if we amputate at such a level that we end results in a physical damage, then there will be the problem will be that one leg will continue to grow, the other will not grow, and eventually producing an LLD or limb length discrepancies. Usually, this is how it's been contracted: extendable or expandable endoprosthesis, that you can lengthen them over time. Then other option is internal lengthening, then invasive versus non-invasive, that sometimes when LLD has developed, we can, depending upon, we can, then there are different options. You can shorten the other leg, the normal leg, or you can lengthen the leg which is actually involved. Different tumors usually, for example, in case of osteosarcoma, usually most common area for the most common tumor in bone is usually osteosarcoma. Next most is chondrosarcoma, and then third most is Ewing. And osteosarcoma and Ewing, the most common area involved is actually distal metaphysis of the femur and the proximal tibial metaphysis. So most common area which is involved is actually knee. The other option, as I just told you, is actually intracardiac resection, that you just take out the tumor and take out all that area, clear that off, and the normal bone, for example, ankle joint, if it is spared, you can rotate it 180-degree, use it as a knee so that it can act as a hinge joint of a knee, and you can use prosthesis for the leg then. That is actually recreating a knee joint by use of an ankle joint, and this is termed as rotationoplasty. Now, coming to the neoadjuvant and adjuvant therapies, as we know that not all tumors need surgery at times. Sometimes nowadays there's a huge chemotherapy has a huge role in radiotherapy as well, and definitely most of the bone tumors are usually, although radio resistant, but they do respond to chemotherapeutic agents. So the role of neoadjuvant chemotherapy and adjuvant chemotherapy, similarly radiotherapy for resistance cases has also sprung up. And usually nowadays, initially the neoadjuvant chemotherapy is always given so that the tumor can shrink in size, and we have to resect out less number of normal tissue and less small size of the normal bone, and then we can use we have to use a small size of endoprosthesis so that later on the knee can be easily stabilized. It is used for osteosarcoma and Ewing sarcoma. The aim of this chemotherapy is to try to shrink the tumor while also treating the micrometastasis of the disease. How do we assess actually is that we have given the neoadjuvant chemotherapy, then patient undergoes the surgery and the tumor is taken out. That is, the tumor, the part is actually examined by the histopathologist, and they say if that 90% necrosis has occurred, that means that chemotherapy was successful and adjuvant chemotherapy of the same regimen can be used. But if it was not successful, that means this tumor is resistant to this kind of a chemotherapy. Therefore, a different type of chemotherapy has to be given post-operatively. That is how it is. And the classical example is osteosarcoma, that you give them neoadjuvant, then resect it, then wait for the report, and if it is good enough, then you continue with the same regimen as an adjuvant chemotherapy, otherwise you change the regimen. Now, in case of Ewing sarcoma, it's usually most common in children and below the age of 10. So sometimes multimodal neoadjuvant chemotherapy has to be utilized. Initially, it's actually this is one of the rare tumors which is actually radiosensitive. And way back in 90s and early to the 21st century, the most common treatment was radiotherapy. But now the modes of treatment have actually changed. Now it's the general consensus is to give neoadjuvant chemo so that the tumor shrinks and reduces in size, the micromats are treated, and then the resection is done of the tumor, followed by joint stabilization. And once the joint is being stabilized, then if that Ewing sarcoma was sensitive to that chemo regimen, then adjuvant chemotherapy is sometimes also given. As I just told you, why we are giving this neoadjuvant chemo to treat basically subclinical macrometastasis, usually as it is sensitive to chemo as well. Systemic theory is with the local control through radiotherapy and surgery. And if it's involving the knee, you have to resect it out because so that the local control is actually achieved. The most common drugs which are used are vincristine, doxorubicin, cyclophosphamide, alternating ifosfamide, and etoposide. And usually different drugs have different side effects, so we have to keep that in mind, especially in the case of children. Now, important point is that mostly musculoskeletal tumors are radio resistant except those small blue round cell nuclei. For example, classical example is Ewing. But what does actually the radiotherapy do? It's actually high dose radiation. It's mainly broadly divided into external beam radiation and internal beam radiation. Now, external beam is that the patient is lying there on the flat and there's some instrument which is giving externally beam. Internal beam is actually those, for example, brachytherapy for prostate CA. Rather, these radiotherapeutic beads are actually transplanted into the prostate and they're left as such. Patient can go home because those beads are actually secreting radiotherapy, inside the body. That is why they're called internal beam radiation therapy. What they do is they're high speed actually X-rays which are actually used to kill the tumor cells. They destroy radiosensitive tumors or as an adjuvant therapy science. So what actually they do is they produce ions which actually therefore destabilize the DNA. Then there is results in hypoxic type of injury because a lot of free oxygen oxide radicals are being produced, and they actually results in increased apoptosis and killing of the cells. But as they kill the tumor cells, there is always a chance that they can kill the normal cells as well. That is why we have a lot of complications which are associated with radiotherapy and chemotherapy, which can be easily seen in the case of tumor patients. So what are the different strategies for the radiotherapy? In case of primary tumor, there are three main modes of treatment for external beam radiotherapy, which is nowadays utilized. Usually, and other options is usually that can be managed for the local recurrence. These radiotherapy strategies include intensive modulated radiotherapy, carbon ion therapy, and proton therapy. But if the disease is locally advanced, the resection is probably not always possible, or we have such an extensive disease that actually we have not been able to achieve clear free margins after resection. Then for the locally advanced disease, the radiotherapy can also be given. And sometimes we know that probably this limb salvage is not an option, that amputation is always a choice, that it can be even given 15% of the patients. Usually the indications, they are always relative. There is no absolute indication to limb salvage and amputation. Usually the relative include if tumor extends out of the bone and encircles the neurovascular bundle, oncological margins are not clear, then usually the amputation is always a better choice than giving a second limb salvage surgery. Usually tumors, if they're around ankle and foot, because ankle and foot, it's very easy to amputate these areas, plus there is not loss of functional limb in case of ankle or foot amputation. Then around the knee, sometimes we have to do, although below knee or above knee amputation is associated with a lot of functional deficit. But nowadays new techniques, especially in case of prosthesis, newer prosthesis have been developed which give a very good functional outcome, a functional knee which can later on be utilized by the patients. Other option, in case of we have sometimes go for upper limb surgery, especially if it is involving the neurovascular bundle. Sometimes upper limb amputation may also have to be performed. In case of pelvis, as I just told you, if a patient presents a case of chondrosarcoma, present with irresectable mass, then probably the amputation is a better good option, and it's going to give more survival benefit to the patient rather than performing a wide local resection or giving it a limb salvage surgery. So we have covered in this section that what is the primary management of the tumors. That all starts with the history, then the examination, then first of all, before we are going for the diagnosis, we have to go for non-invasive investigations, which include X-ray, MRI, CT scan, and bone scans. Once we have sure what is the tumor and what is most likely lesion, whether it's benign or malignant, then we confirm our diagnosis by biopsy. And once the biopsy has been formed, then the next stage is actually the management of the chemotherapeutic and surgical management of that tumor. Chemotherapeutic agents usually given in form of neoadjuvant and adjuvant treatments. Similarly, for resistant cases or irresectable cases, radiotherapy is one of the options. But surgical resection includes intralesional or marginal for benign and benign aggressive, and wide local and radical excision for malignant tumors. Thank you very much. Keep watching sqadia.com.